Good evening, everybody. Welcome to tonight's IDF Forum, Health Insurance for the PI Community. We are so glad to have you here with us, and we are looking forward to receiving some wonderful information about private insurance and public insurance. I'm Kathy Antela, Vice President of Education, and I will be your MC for the evening. For over 40 years, the Immunodeficiency Foundation has served as the trusted organization for the PI, primary immunodeficiency community, with a mission of improving the diagnosis, treatment, and quality of life of people affected by PI through fostering a community empowered by advocacy, education, and research. We truly value our role as a patient advocacy organization. As a result of our mission, IDF seeks to ensure that everyone in the United States affected by PI has a fully informed understanding of the diagnosis that affects them, all available treatment options, the expected standard of care, and all of their opportunities available for connection and support within the PI community. Our forums in so many of our programs are made possible by our wonderful sponsors, and it is due to their partnerships and contributions that we're able to provide tonight's event, along with many others, to the PI community. So at this time, I would like to thank our 2022 sponsors: CSL Behring, Grifols, Takeda, Horizon, Accredo, Octapharma, ADMA Biologics, AstraZeneca, Pharming, X4 Pharmaceuticals, Kedrion Biopharma, and Enzavant. We cannot thank you enough for partnering with us and for the wonderful support you provide to the PI community. And tonight's featured sponsors are CSL Behring, Grifols, and Takeda. And right now, they have a few words for us.
For more than 100 years, we've turned innovative thinking into solutions. CSL's investment in innovation has helped to develop a robust pipeline of safe and effective medicines and improve existing ones so that we can bring patients meaningful innovations and advancements that make their lives better.
Hi, my name is Ricky Mensch, and I'm one of Grifols' immunoglobulin certified nurse educators. As part of Grifols, whose mission is to improve the health and well-being of people around the world, the nurses support the PI community through education of healthcare providers on all aspects of IG care. Our goal is to improve medical outcomes and quality of life. Grifols is dedicated to ensuring that people who need plasma products have access to them. They do this through plasma donation awareness, sustainable supply efforts, and education to increase the early identification and treatment of PIDD. For more information about Grifols, please visit us at grifols.com.
My name is Dana Fladhammer. At Takeda, I am the Director of IG Community Support. You might know the team I'm lucky enough to be a part of as the MyIG Source Patient Advocates. I know that throughout my journey as a mom of 4 children living with primary immunodeficiency, the IDF has been simply an invaluable resource to me. I hope you learn a ton, and if you need us, know that nobody should ever have to do this alone.
Introducing tonight's presenter, who is Stephanie Steele, and she has been with IDF since last year. She is our community engagement manager. So when you are sending a question to IDF through Ask IDF, or you're calling the 800 number with a question, whether it be about support or health insurance, Stephanie's the one behind the scenes triaging your question and very often answering your question. And throughout Stephanie's presentation, please feel free to submit your questions to the Q&A. The icon should be at the bottom of your screen. Just click on that Q&A and send your question in. And during the Q&A time, Stephanie and Abe, who you'll meet in a few minutes, will answer as many of them as possible. And at this time, Stephanie, I am going to turn it over to you. So feel free to unmute, and I will just move your slides forward when you ask me to do that.
Thank you, Kathy. As Kathy said, I'm Stephanie Steele. I am the PI Community Engagement Manager here at IDF. I have been here for 8 months. I have a background at a specialty pharmacy. I was there for 10 years. So I have a lot of good information for you when it comes to health insurance. Tonight, we're going to discuss prior authorizations, denials, appeals, go over different options for copay assistance. We'll talk about private insurance and then everyone's favorite, Medicare. So we'll go ahead and get started. So initially, you're going to go see your doctor. You may see an immunologist. You may see a different type of physician when you are initially diagnosed. It is very important that you make sure you have a thorough workup when you're being diagnosed. And when I say this, I mean, don't just have IgG levels drawn. Make sure you have what is called a pneumococcal challenge. That will be the final step in your labs that you will need to be diagnosed. And I say this because I'll give you an example. I spoke with an individual recently who was diagnosed by a physician that was not an immunologist. And this person was nearing Medicare age. And if you, they had IgG levels drawn and that was all. They were low. Now, this doctor was not going to do a pneumococcal challenge. Now, when a person becomes Medicare age, if you don't have a complete workup and you've been on therapy, Medicare is going to make you you're going to have to stop therapy if you don't have a complete workup. So it's very important to be sure that you have everything that you need initially so that you don't have to stop therapy for 6 months. So when you're getting worked up, just make sure that you have everything done, including that pneumococcal challenge. Now, the next part of that is it's extremely important to save all of your labs and all of your initial diagnosis that you have. Save all of that paperwork. And another reason I say that is, say you're diagnosed when you're 50, when you turn 65 and it's time to have Medicare, if you can't find any of that paperwork or any of those labs and no one can put their hands on them or find them, you're going to have to stop therapy for 6 months because you're not going to find a specialty pharmacy that will ship you out your medication. So it's very important to hold on to all of that paperwork, all of that lab work, all of those clinicals that you can get your hands on when you are initially diagnosed. Okay, so when it comes to private insurance, when you're choosing a plan, there are several things that you want to look at. You want to make sure that you're going with your provider that is, make sure that your provider is in network. Next, you want to look at the copays, the deductible, the cost of insurance, and then how often you really go to the doctor. If you don't have many other ailments and you just have a PI and you only go a couple times a year, maybe you're going to go with one that has the, the higher copay, but the cheaper out of pocket. So really look at those different things when you're choosing your plan. Now, something else that's important, you're not going to know what medications are on a formulary until you've already picked your plan. So don't be surprised if when you get your plan and if your medication is not on that formulary, you might have to switch. Or if it's something that you've had trouble with in the past and there's nothing good on that formulary, your doctor may have to do some work with the insurance company, such as a non-formulary exception or things like that. Now we also have our Medicare, which we have Medicare A, B, D, and then we have advantage plans and secondaries and supplements. Now, IG therapy is covered either as a pharmacy benefit or a medical benefit. You actually don't get to pick which way this goes. This is all based upon your diagnosis when it comes to Medicare. When it comes to your private insurance, you won't know how it's going to be billed until your benefits are run. So even when you're choosing your plan, you won't have any idea until your prescription's sent to the specialty pharmacy. The pharmacy is going to run your benefits, and they're going to come back and tell you if it needs to go through the medical benefit or the pharmacy benefit based upon your plan. So it's not something that you have a choice about. Next, Medicaid. This is based upon income. You go to your local job and family service department to get signed up. The question that we get frequently is, what happens with our kids as they get older and it's time for them to, go on to their own plan. Something that caregivers just need to know is they can assist or fill out the paperwork for that person that is now turning 18. But you just need to have all of the information, and you can take care of that for them, but they're still eligible for Medicaid even when they turn 18. Next slide, please. Okay, so we don't need to worry about pre-existing conditions anymore when it comes to choosing a plan. Pre-existing conditions are a thing of the past, so you don't have to worry, I have a PI, am I going to get coverage? You don't have to worry about that. You're going to get it. So that's no longer an issue. When you are using an in-network provider on your plan, all of your preventative services, your colonoscopies, your mammograms, your yearly physicals, those are all going to be covered with no out-of-pocket cost to you when you're using your public plans, or excuse me, private plans. Next, there are some plans that do have lifetime maximums. Medicare, that's not an issue, but with some private plans, you do need to look at the plan and see if there is a lifetime max. I'll give you an example. I worked with an individual at the specialty pharmacy, and every month we would fill her meds, and she got to a point where she had reached $750,000 in her lifetime. And fortunately, the insurance company let us know, hey, she's getting close to her lifetime max. And they also let the individual know. So you do get good communication from what I have seen from your insurance company. But not all plans have that lifetime max. You just have to pay attention. And if you do have that, you'll know it's time to get new insurance when you get to that point. So your annual out-of-pocket limits, the nice thing is once you hit your out-of-pocket, you are covered at 100%. You're not going to have to worry about paying another thing. So once you hit that out of pocket, you are good to go for the year. And that is an annual yearly thing that will start over. Now, when it comes to your dependents, fortunately now they can stay on your plan until they are at the age of 26, which is very nice. You don't have to worry about that. And then when they do turn 26, it's time for them to choose their own plan. Every plan is different. And let me give you an example. If you're on, when you are on your IG therapy, say you're utilizing your specialty pharmacy, and you get 4 weeks of medication at a time. That your plan is going to end, we'll say, the last day of May. Especially pharmacy can't ship you more than 4 weeks of medication, but they can always ship you 1 week and then ship more later, or they can ship 2 weeks and then ship 4, and then ship 3 weeks or then ship 4. So you can plan it out so that you can get your shipment, and then that last week of the month, if you have a pharmacy benefit, you can get a whole nother month of meds so that your new insurance company can have time to work on the new authorization that you're going to have. So that's just something to keep in mind. You have some wiggle room when it comes to how many doses need to be shipped at a time. So keep that in mind when insurance is changing. Now, some insurance companies make it more challenging than others to get on therapy. We'll talk about patients or individuals with a diagnosis of non-familial hypogammaglobulinemia. Some companies want to see 2 IgG levels less than 400. Other insurance companies want to see IgG levels less than 600. So different insurance companies have different standards. Sometimes when it comes to little things like that, but when it comes to pneumococcal challenges and being diagnosed, you have to have that complete workup. So some good things to think about. What is my out-of-pocket maximum going to be? When looking at the different plans, think about what can what's going to be more reasonable for you and your family. The maximum out-of-pocket is what you're going to have to pay out of pocket in a year before everything is covered at 100%. Now, when it comes to deductibles, you pay your deductible first. Now, something that some plans, when you pay your deductible, that actually is included in your out-of-pocket max. Sometimes it is not. Yeah, sometimes it's included, sometimes it's not. Every plan is different, so you have to find out. But again, this is for private insurance only. And then something else to think about, when you're utilizing in-network benefits versus out-of-network benefits, there are times that out-of-network benefits will cross-accumulate, and the money that you pay towards out-of-network benefits would actually count towards in-network benefits as well. That's actually very beneficial, because once you've met that out-of-pocket, then you can see doctors that are in-network and out-of-network, and everything's already been met. So that's a good thing to think about. If the numbers cross-accumulate, that is the key word, the cross-accumulation. Next, which is not something that anyone wants to hear, is the copay accumulator. Copay accumulators are, they're not specific to any insurance company. And what this is they're for private insurance only. So manufacturer copay cards are available to anyone that is on any product. As long as we're talking about private insurance and the individual is above age 2. So if a plan has a copay accumulator, these copay assistance cards actually will not be valid because of the plan. So just an example, we'll say someone that's on Cobra, the copay assistance is for $20,000. You can have the copay accumulator. You cannot know that you have the copay accumulator. You can be paying towards the medical benefit and think that this entire time that things are being covered, and then find out that you have a copay accumulator. And what that means is that all of this money that you think is being covered by the copay card, it actually isn't going to. And it won't kick in until you've already met your out of pocket. So it's essentially, it's not doing you any good at all. So when you're picking your plan, it's very important to see if the copay accumulator is in place. Now, what IDF is working very hard on this. There are now 14 states. Maine was the most recent one that is signed to make copay accumulators not legal. So IDF is working. We know this is a huge problem for our community. So we are working on this situation. It's a problem. So IDF is working on it diligently. Next slide, please. Okay, so again, something else to look at are my physicians in the network, in the plans network. Very important. You may find that some of your physicians are and some of them aren't. And then you have to make a choice, which makes it not so fun, but it's very important to make sure that you have your physicians that you really, really care about and want to stay with are in that plans network. Again, are there out of network benefits? This is where that cross accumulation would come into play, where you can go ahead and use those out of network benefits, but it counts towards your in-network benefits as well. So that money works both ways. And then you could still see both types of physicians. Oh, so here's the big question. How is my IG therapy covered? Okay, so with private insurance and with Medicare, you don't get to pick if it goes through medical or if it goes through pharmacy. We don't have a choice there. And if you have private insurance, there's no way you're going to know. If you have Medicare, you're going to know up front exactly which way this is going to be covered. When it comes to Medicare, billing is strictly based upon your diagnosis code. Strictly based upon your diagnosis code. So there's a handful of diagnosis codes that are considered qualifying diagnosis codes. All of those go through Medicare Part B as in boy and are billed through the medical side. All of the other ones are considered non-qualifying. Those go through Medicare Part D as in drug, and there's no changing it. Your labs are what they are. You can't go to your doctor and say, gosh, I don't like that. I don't like those Part D numbers. I don't like that. I want to go to Part B. Well, your doctor can't just say, oh, okay, well, we'll just switch this. It's all in black and white in your lab work and in your clinicals. So it's not something that can be changed. Options for site of care. You have so many options for site of care. You are not stuck in one place unless your physician prefers. But you can do home therapy. You can go to an infusion suite. These are all choices that you can discuss with your physician, but you are not stuck at one place no matter what type of insurance you have. Okay, do I need a referral to see a specialist? With Medicare? Nope. With Medicaid? Sometimes. With your private plans? Sometimes. You have to check with your plan. And again, every plan is different. So you're just going, when you get your new plan, you're just going to have to really dig in deep and honestly just have access to the internet or have your plan right in front of you so that you can keep referring to it, because again, everything goes back to they're all different. The services that require prior authorization. My goodness, almost everything when it comes to IG therapy, everything. When it comes to nursing, even your ancillary medications like your LMX or your EMLA, obviously the main medication itself, those all require prior authorizations. Okay, so let's say you're on medication and you've been on it for 5 years, you're doing great, the new year rolls around and boom, that medication's no longer on formulary. what do? Well, sometimes, say you've been on other medications in the past and you've tried and you've done terrible with them. You've had anaphylaxis or you've had other terrible reactions, and your doctor has documentation on all of that. So your doctor could do what is called a non-formulary exception appeal, and try to get you that medication that you know works for you if it's not on the insurance's formulary. Now, if you haven't tried any of the other ones, you're going to have to change. And that's what really stinks. A lot of times doctors don't even get to pick what medication patients or individuals are on anymore. It's really based upon what's on the formulary, because we have to go with what the insurance says you can have, unfortunately. So it's frustrating, but it happens. So sometimes you might have to switch medication. Okay. Yes, most private plans do have a case manager that can assist you with your benefits. This can all get very, very sticky and confusing, and there are case managers there to help you through all of this. You just need to call and request one. They'll talk you through everything. Next slide, please. Okay, so working with your specialty pharmacy. Your doctor is going to send over your prescription, and the first thing that's going to happen is the specialty pharmacy is going to check your benefits. They're going to go through everything, and it will show them if your medication is going to go through your medical benefit, your pharmacy benefit, if that medication is one of the preferred drugs for your plan. If it's not, what drugs are preferred. Also, you'll find out if that pharmacy is one that you can use. It's not uncommon for a doctor to send a prescription to a couple of different pharmacies, knowing that there's a good chance that one of those pharmacies will not be able to fill that drug based on the individual's insurance plan. All insurance companies follow Medicare guidelines. So this goes back to the pneumococcal challenge that I was talking about. If someone has, say we're talking about someone that has CVID, you know that you have to have what they're looking for. To be diagnosed with CVID, we're looking for 2 low IgG levels. You have to have failed your pneumococcal titers and then have a clinical history of infections. So all of the other insurance companies follow those Medicare guidelines. That's the standard. So they're all the same. They all follow those same guidelines. Okay. All right, now understanding Medicare. Okay, like I said, everything with Medicare comes down to your diagnosis code. There's a hand. Okay. We have a list of those diagnosis codes that are covered, that are considered qualifying, that go through Part B. You can see those if you go to that link that's on our page. But again, those are the covered, and then all of the other ones go through Part D as in drug. Again, your doctor can't change that. It's Medicare fraud. It's not going to happen. So you can have them review it and see if something isn't correct. Sometimes prescriptions are sent to a pharmacy and the pharmacy comes back and says, yeah, something isn't really adding up. You know, this clinical information doesn't match the diagnosis code. And sometimes things are changed. However, patient can't request and say, I want this specific diagnosis code because it's this and this is the one I want. So it can't happen. Now, with Medicare Part B, we'll just say someone's on IV Gamma Guard. Medicare is going to cover 80% of the cost of that product. a secondary or supplement is going to pick up the 20% cost of that product. So right there, you're going to be covered at 100%. Now, that being said, Medicare does not cover nursing and supplies. However, Medicare did create a project that you need to sign up for that will cover nursing and supplies. This is called the IVIG demonstration project. Now, there's a form and instructions online. It's all very specific. If you miss one box when you're filling out this form, Medicare will actually reject it and send it back. You can't send in the form early. So you have to wait until the day that your Medicare becomes effective to send this in. The patient needs to sign it. The physician needs to sign it. Let's say, Sally is going to turn 65 on May 10th and she needs to get her form in. If she gets it in by the 15th of the month and everything is correct, she would be eligible by June 1st. Now, let's say she didn't get it in until the 20th. She actually would not be eligible for these services until July 1st. So you have to have it in by the 15th of the month to have it effective the next month. If it's later than the 15th, it's actually going to be the following month. So if this is something that you know you're going to have to do, get on it right away. And this is something that you can call Medicare and check on and see if you've been approved. They can send the information to the specialty pharmacy for you. But again, every box has to be filled out. This is only needed for IV supplies, and very important to make sure this is taken care of. Okay, so we know that Medicare Part B also covers our medical coverage. It covers our outpatient care, our home health, our durable medical equipment, our walkers, our crutches, hospital beds, and then it covers all of our preventative services, our yearly well visits, our screenings, our mammograms, our vaccines, things like that. Okay, so for 2022, the Part B deductible is $233. After that, again, Medicare covers 80% of the cost of your IG therapy. Your secondary or supplement will cover the other 20%. The nice thing about this is that no prior authorization is needed for IG therapy when you're utilizing your Part B benefit. There's clinical staff at every specialty pharmacy that's going to go through all of your clinicals that the doctor sends over like a fine-tooth comb. And they're going to make sure that what they're sending in is the correct diagnosis, because you don't need an auth. They want to make sure that what they're sending out is correct. If someone's chart is audited and it's not the right diagnosis, Medicare is going to take back all their money. So they're going to make sure that what they have on file is correct and accurate, and you're going to get your medication quickly because you don't need that auth. So things move pretty quick with Medicare Part B. Just make sure as soon as you get your cards, you get everything over to the pharmacy. They're going to want a copy of the front and back if you can. That makes things move quickly. You can get all that information over to them. But again, they can't start working on any of this until the day it becomes effective. Okay. Medicare Part D. Okay, so we have a list of all the diagnosis codes that are not covered or considered non-qualifying that don't go through Part B. These are like your non-familial hypogammaglobulinemia, those diagnoses. Okay, so these numbers are a little different. So you're going to pay the full amount of the costs before the $233 annual deductible is met. So you're going to pay your deductible, and then after that, you're going to go into a point where you're going to pay towards your donut hole. Next slide, Kathy, please. Okay. Before you get to the donut hole, you're going to be in the coverage gap. You're going to spend a total of $4,430, and you're going to pay no more than 25% the total cost of the drug during this period. Now that $4,430, that's going to go towards the donut hole, which we'll talk about in just a minute. Kathy, you can go to the next slide. Okay, so the donut hole for 2022 is $7,050. So you're going to pay your deductible. You're going to pay that $7,050. Then after that's been met, with every shipment of medication you get, you're responsible for 5% the total cost of the drug. 5%. So if we're talking about, you know, a shipment of, I don't even have to tell you how expensive it is. You already know. You know, say you're getting, I don't know, 8 grams of Hizentra and you're infusing weekly. You're going to have just to throw out a number, a $10,000 bill. You're going to have to pay 5% of that $10,000. So, and I'm just going to give you an example of how much this increases every year. In 2021, that donut hole was $6,550, and now it's gone up to $7,050. So it goes up every year. Prior authorizations are needed when utilizing this Part D benefit. It's going to take longer to get going. You're going to need re-auth with this. So you're going to have lab work done every 6 months, so that you can make sure that your specialty pharmacy has what they need for when they resubmit it. And also, all of your ancillary medications go through Part D. Yeah. All your ancillary meds, generic epinephrine, it's going to be a lot cheaper for you. Medicaid, again, based on income, go to your Job and Family Service Department. Low income subsidy. This is for individuals that have Medicare Part D coverage. If you have low income, you can apply for LIS at medicare.gov. It makes your copays drastically lower. And when I say drastically, I mean a copay of like $8 as opposed to the other Part D numbers that we saw. So if you have low income, that's definitely something to look into if no one has mentioned that to you before. Next slide. Okay, insurance denials. They happen more frequently than you would know. New mind going back. Okay, thank you. They happen more frequently than you would think. Copies of the denials are sent to patients and physicians with the reason for the denial. The specialty pharmacy does not get that. So if they call you and they're asking for a copy of that, that's why. They just don't get it. It's going to give the reason for the denial on there, and that's what they need to work with. The doctor's options with a denial, number one is the peer-to-peer, which is ideal. The doctor will actually call the insurance company and speak directly with a physician and explain the situation. You know, this is why my patient needs this medication. This, you know, go over everything. Now, when a doctor is doing a peer-to-peer, you want to make sure that they are actually speaking with an immunologist. The other option is just an appeal with a letter of medical necessity. And that happens as well, but it just takes a little bit longer to get a response, because with a peer-to-peer, the doctor knows immediately what the response is. After 2 denials, you'll go to an external appeal. The specialty pharmacy isn't going to help you with that. You're actually going to do it through the state, and that is a very lengthy process. You're almost better off just getting new insurance and starting over. Next slide. Okay. Prior authorizations are required for all IG therapy. They can take anywhere from a couple of days. I've seen them take up to a couple of months. It just depends. Again, it depends upon the insurance company. Insurance companies are going to require reauthorizations. So you're going to need to get lab work done every 6 months. Sometimes it's every year, so that the specialty pharmacy or doctor's office can go ahead and submit that to the insurance company. Some plans are becoming more strict. I have seen some that are requiring auths every 3 months, which is crazy. But something that some physicians do is when they are getting an individual started on therapy, they'll get them started on a sample program so they can go ahead and get going while they work on the authorization. So if that's something that you think would be, you can ask your doctor if that's a good idea or not. Next. Okay. Managing expenses. The nice thing about flex spend accounts is the medication or the money is taken out pre-tax and put onto a card or in an account. So, you know, you can kind of plan ahead, and if you know roughly what your out of pocket might be for the year, you can go ahead and, you know, decide how much money would be good for you and put it aside. And it comes out tax-free. Also, specialty pharmacies have financial assistance programs. You will never hear them tell you that they have it. You have to ask them for it. It's enticement if they tell you it's not legal, but they all have them. You just need to ask. Also, with every drug out there on the market, if it's a private insurance, you are eligible for manufacturer copay assistance. It's out there. They're not going to ask you how much money you make. It's only simply because you are on that product, you are eligible for manufacturer copay assistance. And we have the link on the screen so you can get the phone numbers or the different email addresses for all of those. Next slide. Okay, now here are some other assistance programs that are out there. The first is the Assistance Fund. Next is the Patient Advocate Foundation, and last is PSI, just to name a few. If you need assistance, and you can reach out to those. Okay, an advanced beneficiary notice. I'll go over this quickly. These are for individuals that have Medicare and then also have a secondary insurance. There are situations where a pharmacy knows that Medicare will not pay for the medication, but the secondary will. So they're going to go ahead and get that prior authorization through the secondary insurance company. However, you're going to get a form, this ABN form, and it's going to look a little scary because it's going to say you are going to be held responsible for such and such amount of money. So $20,000 a month if your other insurance doesn't pay for this. Now it looks scary, but by law they have to provide this to you. You can just ensure that you have that off through the secondary, but just to give you a heads up on what an ABN or an advanced beneficiary notice is, they're required by law to have you to provide this to you.
Stephanie, thank you. Thank you. You are brilliant. And I'm so glad we have you to be able to answer so many questions that we have received. And plus, we're going to bring Abe in here in a minute and introduce him to answer questions with you. And so glad that everybody in our community can send their questions to Ask IDF and have them answered. Thank you. Thank you to our sponsors. Thank you, Stephanie, for the information that you shared with us. And we are going to start the Q&A, but first I need to introduce my colleague, Abraham Eunice, who is the Director of Payer Relations and Policy at IDF. And he is going to be joining Stephanie, as I mentioned earlier, during the Q&A. I would also like to introduce my colleague, Colleen Brock, Manager of Medical Programs, who is going to moderate the Q&A. So the three of you unmute yourselves and take it away.
Thank you. Very glad to be here.
Good evening, everybody, or late afternoon for some, I guess. So we're going to get started with the questions. And we have several very good ones. Let's see. Let's start with just some general questions. I have a hard time knowing how my IG will be covered under new plans. Is there a uniform way IG is covered under commercial plans? Is it generally treated as a pharmacy benefit or a medical benefit?
So I'll take this one. So that really depends. You know, usually if it's a Medicare one, it's covered under Part B. But since this is a private commercial, what you want to do is, so each medication that you're going to use or want to use or that has been prescribed to you by your physician, it always comes with a CPT code or a procedure code, right? That's the code that the insurances identify how benefits are going to run through. And so one word that maybe I'd like to share with everybody that is in attendance is that procedure code is typically they will ask for a J code. So it's referred to as a J as in John dash code. And so if you are able to know what the J code is for your medication and you call into your insurance, or if you're shopping for insurances, you can provide them with that J code along with your diagnosis code. And based on that information, your insurance will let you know if this will go through the pharmacy side or through the medical side. Usually we see most IVIG being covered through the medical side along with the durable medical equipment that comes along with that. But you won't find that out until you go through the benefits verification process with each private insurance.
All righty, thanks, Abe. So if you have somebody who is switching from one insurance plan to another, and we're talking private insurance, do you have any words of wisdom as to setting up a plan of action so that there is a smooth transition from one insurance to another?
So, I think the best thing that you can do is know that you're potentially going to have a lapse. If you, unfortunately, it takes some time to get those new prior authorizations in place. As I said earlier, if you can try to time things with the specialty pharmacy, or maybe move an IVIG infusion, you know, a week one way, if your doctor thinks that's okay, just to try to buy a little bit of time, because it is going to take some time to get those new auths put in place.
Yep. And I would like to also add to that, and thank you, Stephanie, is that when, let's say you're switching insurances and you know you started a new job or whatnot, and your job has multiple insurances, you know, or insurance options. So each insurance, depending on your medication, if you're on a specific medication and it has a name, right? You want to really check if your medication name is one of the covered medications that's on the formulary of whatever insurance that you are shopping for. So meaning, you know, you can call your insurance up. You say, this is the medication that I'm looking for. Is this one that is covered by this insurance if I were to join? And again, you can provide them even with that J code, right? And by that J code, depending on what the insurance is, they may lean towards using one brand name versus another, based on things that are outside of your control, right? And they may try to refer you to using another brand, right? So, but if you're happy with the particular brand that you are currently using, it is very important to find out what that J code is and call that insurance that you are looking at shopping for, and just make sure that they cover it and that it's that it's part of their formulary. If not, they may try to switch you. So, and you may not want to be in that kind of situation.
Thank you. When talking about people who are switching, is Cobra available and valid in all 50 states? Or does the size of the employer have anything to do with whether or not they offer Cobra?
I'm going to give that one to you, Abe.
Okay, so Cobra is usually a benefit that is offered by the by the employers, and it is usually I'm not really 100% sure as far as state regulations go. However, I haven't run into a situation where from Illinois to California where people weren't offered Cobra. All Cobra usually is whatever the existing plan was. After, for some reason, there's a loss of employment, let's just say, you are able to start paying whatever your company was paying to keep that plan alive. So meaning it becomes a little bit more of your financial responsibility on the monthly premiums that you are going to pay. But it just extends the expiration date so that the expiration date isn't when you, let's say, lost your job. It becomes a few months, or as long as you want to continue making those premiums. Sometimes they do have limits on how long you can have a Cobra. Sometimes it's 6 months, sometimes it's 1 year. That is more so usually in the benefit plan of whatever employer that you're working with.
Okay. An interesting question. How do families deal with bills from a family member that has passed away? Are they responsible for continuing to pay those medical bills? Do either one of you know the answer to that?
Well, I would say, we are experts when it comes to insurance, but when it comes to collections and things like that after death, not we're not the experts there. But what I will say is, as a private example, when my dad had many medical bills, and once he passed, those were not sent to me. I wasn't really being placed responsible. There may be other situations, legalities that I'm not familiar with, so don't quote us on this, where they may go to the next of kin for some debt. But in my personal experience, at least, I will share with you that these bills were not pinned on me as a son of someone who had a lot of medical bills.
Thank you. So Abe, how does a person get insurance as self-employed in Louisiana or even in any state?
Well, usually the first thing that you want to do is something that you probably heard about. It comes through the Affordable Care Act, and also known as Obamacare. And so you want to go to the Obamacare website, and from there you are able to put in how much money you are making as a family or as a single individual. And then after you put in your your financial numbers along with your age and some basic demographic information, they will actually tell you what plans are available within your state, whether you qualify for Medicaid, because it's important. If you don't have any income, then you probably should visit your local family and health services office, and you would actually probably qualify for Medicaid if you are not making any money right now, or you fall within the financial requirements. But that's the first thing that I would do, is I would visit the Obamacare website. That's what it was called last when I knew about it. But you would go there, plug your information in, and then they would give you the plans that are available based on your zip code.
Thank you. We had a question that came in prior when the person registered for the event, and Stephanie and I had a conversation about this one. It is a parent of a PI kiddo, and they want to prepare in case they pass away, and they want to include something in their will for obtaining private health care that will be adequate for their child. I don't know that that is possible in a will. And what Stephanie and I discussed is whoever becomes the guardian of your minor child would be the one whose health insurance would cover it. So when you are choosing somebody to be a guardian of your child, if they're a minor, that's something that you should consider and maybe even discuss with them. Is their health insurance, and do they have a good plan? And the other thing that you can then do is set aside money in your will to be given to them to cover whatever the cost of their health insurance would be for your child. And Stephanie, I don't know if you learned any more after we had that conversation.
Everything you just said was spot on.
Cool. Yeah, I think that's pretty much the only options that you have. So next question. What are pros and cons of having sub-Q home therapy authorized through medical versus pharmacy?
Well, again, you don't get to choose. So I don't think that there is a pro or con either way, unless you're talking about Medicare. If your coverage is through Part B as in boy, you're gonna have zero out of pocket aside from your deductible. If you're talking about Medicare Part D, we saw those numbers, and most people need financial assistance.
Okay.
So I think that would be the one benefit of going through the medical side.
Well, I would like to send a personal welcome to the person joining us from Germany this evening. And they have submitted a question. They are moving to the United States soon. They have been diagnosed with XLA 30 years ago, and they want to know if they're going to have to be re-diagnosed when they come to the United States to get their insurance.
Well, usually when you begin a new insurance plan, and let's say that it is in the United States, they have to assign you a provider, a primary care provider, and other providers as well. Usually, international prescriptions are still accepted here. So if you already have a prescription, but if the insurance is looking to pay for that prescription or for the cost of that medication, they will need for you to go and see one of their providers, because each insurance has a provider list, and they have, in-network providers and out-of-network providers and non-contracted ones. So I'm assuming, if it's a doctor from Germany, then they would want you to see one of their providers within their network as well. And depending if it's a PPO plan, you can probably go and see the specialist directly, whether they're an immunologist or an allergist. If it's an HMO plan, you will have to see a new primary care doctor, and more than likely they would have to send a referral then to the specialist, and you actually have to follow that protocol. It's very important, though, to bring as much information as you can from Germany, and if it's in the German language, to actually have it translated, more so that you and your new doctor can go over that information, right? To just make sure that your doctor is aware of your patient history.
And Stephanie, that's where you talked about making sure you have that information, correct?
Correct.
So what would they need to bring?
They're going to need to bring their original labs showing that they have no IgG. And unfortunately, it's going to be from when they were tiny. And so hopefully they have those.
All right. So somebody's questioning, sometime in the future, I may want to travel out of the United States for, say, 3 months. Will Medicare cover me getting my immunoglobulins several weeks in advance? So if they're leaving the country, what do they do with their medication? How do they get it?
This is all very case specific. Most specialty pharmacies will not ship out of the United States. If you're going to do this, you need to speak with your specialty pharmacy as soon as possible, months in advance, because if it's going to happen, it's going to take it's going to be quite the exception. And you're going to need to take all of those medications with you on the flight. In your carry-on, I might add. Don't ever check that. Never check that bag.
And if I may also add, so there are things that specialty pharmacies are able to do, such as put in a vacation override up to 90 days usually. So let's say that you're so just like Stephanie said, just make sure that you contact your pharmacy, let them know that you're going on a vacation, and just say, you know, I'm looking for a vacation override for an early refill on my IVIG. And most specialty pharmacies that we're aware of would usually accommodate that.
Okay, Stephanie, you referred to something in your presentation and you used the word catastrophic. And somebody is questioning, what did you mean by catastrophic?
So the catastrophic phase when it comes to Medicare Part D benefits is after you have reached that $7,050 donut hole, and you've already gone through that donut hole and you've paid your deductible and the $7,050. So at that point, every prescription that is filled through your Part D benefit, you will be responsible for 5% of the total cost of the drug.
Okay.
That's the catastrophic phase.
Okay. All right. So moving on to some authorization copay kinds of issues. This one has to do, in what situations can you appeal to your insurance to go to a provider who is not in your plan in a neighboring state? Would this appeal be a one-time occasion, or can they make it permanent so that you can see a doctor crossing the state lines?
If you, you know, I was going to ask if you could repeat that question because it sounded like a doctor traveling from one state to another, right?
The insurance, a provider who's not in your plan in a neighboring state at an academic center.
Okay.
And I guess the insurance isn't going to cover it, so they're appealing it. Would it be, do they ask for a one-time appeal for a one visit, or can they ask to routinely see that person?
So if they really like that doctor and, you know, maybe sometimes, you know, it really depends. Some people live really near a state line. And so it might be even closer to go, you know, be beyond that state line to see a particular provider. And insurances do take that into account, that if you travel, let's say, 30 miles across a state line to see a provider that you want to see, and your other option is 140 miles within your state, but deeper into your state, right? They will make an exception for an out-of-network provider. So for that one, if you really want to see that provider, whether you really like them or because it geographically works, you would be asking for an appeal for an out-of-network provider.
And I can give like a personal example. So where I live, I am 15 miles from a major health facility. My daughter has primary immune deficiency, and she's also had a bone marrow and a small bowel and colon transplant. Now, she needed to see a bone marrow transplant doctor, and they have some here at our local hospital. However, she also needed to see the solid organ transplant physicians, and we wanted her to have everything done at one facility, which is 200 miles away. So we were granted an exception for the 9 years to see the physicians at the other facility, and it's been in place the entire time. Now, they frequently need to get authorizations for you know, different appointments and procedures. However, we have been granted that, so it can happen. Yeah.
And the facility takes care of those authorizations. You don't need to do them.
That is correct.
Good. All right. So how do you find out if an insurance company has copay accumulators? Some of them are not being very forthcoming in telling you that that's what they have, and then it's kind of sprung on you when you pick that insurance.
Yep.
Very plan specific. Unfortunately, every insurance company has a plan that has one. However, it's very specific to the plan. Now, something else, this is a plan that your employer has picked. So say you're dealing with a copay accumulator situation right now. This is actually something that you can bring to your employer's attention, so that potentially next year they can choose a plan that does not have this in place.
And you would go to HR, human resources.
That is correct.
So any insurance issues that you have would go through, if you're working, would go through HR or human resources. That would be the department you would want.
Yep. They usually call it the benefits office. Yep.
Ah, okay.
Yep. And I want to sort of add to that, to the accumulator situation. So if I want to know if a specific insurance company has accumulators, I would literally ask them, if I have copay assistance that covers my copay, will my deductible change? Meaning, like, will that be applied towards my deductible? If I have a $500 deductible and I received copay assistance of $200, my deductible should drop to $300, right? 500 minus the 200. If for some reason there's an accumulator in play, you receive that copay assistance for 200 and your deductible does not change, they're still obligating you to that full 500. So just as a basic question, when you call, your member services, of the insurance company that you have, all you really have to ask them is, will my copay assistance be applied, or will it affect my deductible? And if the answer is no, then they are using some kind of copay accumulator. To also add to that, copay accumulators programs are also directed state by state. So some states don't allow them, and some states do. So it's very important to check state laws and to be up to date on which states permit accumulators. But the quickest way to know is just to literally ask them, does the copay assistance apply or affect my deductible?
Well, and you jumped right into the next question, Abe, that you can answer. How can a person help get state legislation in Iowa involved in making copay accumulators illegal?
Yep. We have a representative. She's not on the call right now, Jamie Sexton. She's in charge of state-related matters and policy, and she has already been diligently working within many states on on different either legislations that we are supporting, and different ways where we could do that. And I believe that a lot of them are done on the state level. I would say maybe the Senate's office, but Jamie, is very much in charge of state-related matters. And anytime that there's something that we're trying to do on the legal side of things on a state level, we do have her as a representative. So what I would say to that is that if you're from a particular state and you are dealing with a situation where there's a copay accumulator and it's really causing you financial burden, please do reach out to us from Ask IDF, share your story. We will then be able to take that story and relay it to state representatives that Jamie's working with, and we will do our best to help prohibit these programs on a state level.
Thank you, Colleen. Thank you, Stephanie. Thank you, Abe, and thank you to our featured sponsors tonight, CSL Behring, Grifols, and Takeda. And as always, thank you to each and every single one of you who joined us tonight, who submitted such great questions. We are so happy to have you with us and wish you a wonderful rest of the evening, and look forward to seeing you on May 19th when we have a nurse with us sharing wonderful information about IG therapy. And again on June 2nd, when actually Abe and our Vice President of Public Policy, Lynn, will be joining us. And that night it's all about Medicare. Medicare is the topic. So thank you again Take care and good night.